So a 58 years old lady, homemaker from Trivandrum, came with complaints of abdominal pain, loss of appetite, and early satiety since 3 months. Patient was apparently well 3 months back when she had complaints of abdominal pain, localized to the lower abdomen, insidious onset, dull aching, intermittent, non-radiating, not associated with food intake, not associated with nausea and vomiting, no aggravating or relieving factors. Pain has progressively increased in severity over the last 3 months. She also has complaints of loss of appetite associated with early satiety after meals. No history of weight loss, fever, no history of altered bowel habits, no history of blackish stools, blood in stools, no history of vomiting post meals, blood in vomitus, no history of PV bleeding, PV discharge, vaginal mass, no history of yellowish discoloration of skin and eyes, no history of cough, chest pain, dyspnea, coughing of blood, no history of back pain, bilateral lower limb swelling, and no lump in breast. Known case of hypertension since 1 year on antihypertensives and no history of medical or surgical illness in the past. Her menstrual obstetric history, she attained menarche at 14 years, regular cycles every 28 days, 4 days, moderate flow, married at 21 years of age, P1L1, full-term normal delivery, first child at 25 years, breastfed for 2 years, no history of OC pill use, no tubal sterilization history, attained menopause at 40 years, no history of HRT use. Her diet is decreased, her sleep, bowel, bladder is normal, no history of drug allergies, no history of smoking or alcohol, no history of cancer in the family, treatment history, there's nothing. So to summarize, it's a 58 years old postmenopausal lady, known case of hypertension with complaints of pain in abdomen since 3 months associated with loss of appetite. Should I continue, sir?
Yeah, so loss of appetite, you can just change that to decreased satiety.
Yes, sir, decreased satiety.
Yeah. Okay, so can we just go back? I would like to, cover some things that can be asked. Okay, so you yeah, so yeah, you can go to the third slide. So as was presented, these are the, usually get abdominal pain, you get loss of appetite, early satiety. You can also get abdominal distension. That is another symptom that can be seen, right? So those are the common positive symptoms that you see in a case of CEO ovary. So now coming to this particular case, when you talk about lower abdominal pain, right? What are the organs that can be, or what are the malignancies where you can get lower abdominal pain?
The ovarian malignancies, the uterine malignancies, or colorectal malignancy, colon
Yeah,
tumors.
you have nailed all three. Usually, it can be a colon malignancy. Uh, if it's a right lower abdomen, you can get a cecal malignancy, right? Uh, Uterine malignancies, and of course, malignancies involving the adnexal structures, the fallopian tube and the ovary. Okay, so that's how you localize it. So we can just based on the location of the abdominal pain that the patient is saying, you can localize it to these particular organs, right?
Yes.
Okay, early satiety, right? Early loss of appetite and early satiety after meals. Usually, when do you tend to get that in, any malignancy involving the abdominal pelvic area? What are the conditions in which you can get that?
When a tumor is compressing on the bowel or stomach, that's when you get early satiety.
Yeah. Or if there is any enlargement of organs like the spleen, right? So conditions where there are severe splenomegaly, you can get loss of appetite and early satiety. Or if there's a large tumor, like you said, compressing on the bowels, right? Especially it's seen in ovarian malignancy. So there also you can get early satiety. Um, can we go to the next slide, please?
Yes.
So if you look at the history here, so we had said no history of weight loss, fever, night sweats, right? So those are your typical B symptoms, right?
Yes.
And we do that to rule out.
Lymphoma.
Yeah. So can you, once I've mentioned this is the last one, but can you define these symptoms?
Yes, sir. So, fever more than 38 degrees or more than 100.4 Fahrenheit lasting for about 2 weeks. Then weight loss of more than 10% over the last 6 months. And night sweats lasting about drenching night sweats for 1 month.
Yeah. All of which cannot be explained by
By infection or any other cause.
cause. Yeah.
Most probably
So
infection.
it is persistent and it cannot be explained by any other cause. Okay, so yeah, you're right regarding that. So we have ruled out, of course, a lot of lymphomas can present with an abdominal mass, and we've ruled that out. Now, coming to any abdominal pain, obviously, the next thing you need to rule out is GI malignancies, right? So we have
Yeah.
asked a plethora of negative histories like altered bowel habits, blackish stools, blood in stools, vomiting post meals, blood and vomitus, PV bleeding, PV discharge. Sorry, blood and vomitus. So altered bowels to blood and vomitus, those are pertaining to GI malignancies. In an ovarian malignancy, where can you get altered bowel habits?
When it is compressing on the colon. Uh,
Yeah, so you can have like omental deposits, right? Extensive omental peritoneal
yes.
deposits that can
Yes.
cause constipation. You can have what do you call invasion of the GI, right? So if they have colonic invasion, etc., there also you can get blackish stools, you can get altered bowel habits, uh, and also so melena, and it can sort of resemble a GI malignancy when it invades the colon, which is commonly seen in very advanced cases. So mostly peritoneal deposits, invasion of the colon, etc. Um, Also, if you in certain case of mucinous CA ovary, where you can have ovarian masses along with a GI mass, colonic mass as well, there also you can get all these symptoms. So in case of CA ovary, those are the conditions where you tend to get these GI symptoms as well, but for the most part they are not usually seen, right? Okay, what about this
Yes.
PV bleeding that you see? What are we trying to rule out here?
Um, PV bleeding, so if it is a estrogen secreting tumor or another malignancy like cervix malignancy or
Yeah.
postmenopausal bleeding for endometrial cancers.
Yeah, so mainly we're trying to rule out, uterine malignancies, right? Like we
Yes.
said, the lower abdominal pain, the uterus is also located there, like you mentioned earlier. So
Yes.
that we're trying to rule out. But when it comes to CA ovary, you had just mentioned one of the causes. So PV bleeding can be seen in the context of a CA, a carcinoma ovary if it's an endometrioid ovarian cancer. So in that case, around 10% of the cases has a concurrent uterine mass as well. Okay.
Yes.
So endometrioid ovarian cancer can also present with the uterine mass in 10% of the cases. Also, like you mentioned, in like granulosa cell tumors that present
Yes.
in adults, they also present with PV bleeding.
Yes.
So those are two commonly seen conditions where you can have associated PV bleeding. Okay, now right. So you had mentioned back pain, right? Where can you get back pain in? What is the most common cause for back pain in a ovarian malignancy?
So I'm not sure
Yeah,
exactly.
so it is retropedal nodal spread. Okay,
Okay.
so apart from the momentum, the common side it spreads to the retropedal node. So there also you can get back pain. Now all this cuff, chest pain, dyspnea, and all that, basically the lung involvement can also be there. So once you've moved past PV bleeding, discharge, and vaginal mass, we are looking at the negative history for distant spread, right? So liver
Yes.
mets we have looked at, lung mets, pleural effusion we have looked at with the respiratory symptoms, back pain to see if any retropedal nodes are involved. Rarely you can also have involvement of the vertebrae, right? The bones can also be involved, especially if it's a non-serous malignancy like your clear cell, etc. You can have bone metastasis as well, although it's not commonly seen in serous. Okay,
Yes.
so now bilateral lower limb swelling. What are the scenarios in which you can get bilateral lower limb swelling in a CA ovary case?
Um, a large mass compressing on the vein, the IVC, which may
Yeah.
cause, or lymph nodal involvement, inguinal lymph node,
Yeah. Any other that
unilateral.
you can think of?
DVT
Yeah, that's
in
that's
malignancy.
good.
Yes.
One more. We
Uh,
mentioned early satiety, right?
yes.
Yeah. So that
Albumin, hypoalbuminemia.
yeah, very good, very good. So you can get bilateral lower limb swelling, hypoalbuminemia, IVC compression. There's lymphatic obstruction with inguinal nodal spread, and also in cases of DVT, because C ovaries, there's high risk for DVT as well. So those are the causes. Now coming to lump in the breast. What is the significance of lump in the breast in this ovarian malignancy?
Um, Lobular carcinoma of breast is commonly associated with ovarian malignancies.
Okay, I mean uh, that is
Sorry,
valid. I cannot say
so
that's wrong, but
Krukenberg tumor,
before that,
the inherited syndromes, BRCA
yeah,
syndrome.
yeah.
Yes.
So hereditary breast ovarian malignancies, right? So you need to see if there's a concurrent breast malignancy as well. So the history of breast lump is very important. That's number one. Number two is Krukenberg Mets, right? So mostly it is described in GI malignancies. Rarely, it can also occur in breast malignancies, most commonly in invasive lobular carcinoma. So, main answer should be hereditary breast ovarian cancer. Then you can come to Krukenberg Mets and say that breast malignancies, especially invasive lobular carcinoma, can present with ovarian mets, right?
Yes.
Okay, can we move to the next slide, please? Now, here I want to, before this, I want to ask you, like, what are the scenarios in which you can get uh, an acute presentation, right? So presentation less than 1 month. What are the like, in what scenarios do you get a presentation in less than 1 month,
Mhm.
like acute presentation?
So bowel obstruction, but
Obstruction is
acute.
one.
Yeah. Then
So you can have torsion, right?
torsion. Yeah. Right. Right.
Torsion can lead to acute pain. You can have rupture of the cyst that can lead to severe pain, right? You can also have hemorrhage into the into the cyst, so that can also cause acute pain, right? So those are some acute presentations: obstruction, torsion, rupture, and hemorrhage. This torsion, rupture, and hemorrhage is seen in what type of ovarian malignancies?
So yeah, more so in younger age
Yeah,
people.
younger age and in germ cell tumors. Okay,
So,
so germ cell tumors, they tend to have this sort of an acute presentation. Usually, you won't see it with the epithelial ovarian malignancies.
yes.
Okay, now just for completion's sake, I would like to. Do you know anything about the Goff symptom index?
Symptom index, yes, sir. So if the symptoms are occurring more than 12 times a month, and so exact duration, but the frequency is 12, more than 12 times a month,
Yeah,
and in the
and less
last
than
three
1 year,
months,
right?
less than 1 year, yes.
Yeah. So, what are the symptoms that are described in this Goff symptom index?
uh, Dyspepsia, abdominal increased satiety, abdominal fullness, um, pain in abdomen.
Yeah. You mentioned almost half of them. So it's pelvic pain, abdominal pain, increased abdominal size, bloating, feeling full, and difficulty in eating. Okay, so and it's been modified to add loss of appetite, loss of weight, and increased urinary frequency. So, like you said, all these symptoms, if any one of them occur greater than 12 times a month, less than in a span of less than 1 year, then you need to suspect a malignancy and probably investigate further. So that's a Goff symptom index. Now, what are some of the paraneoplastic syndromes with which an ovarian malignancy can present with? Can you name like just a couple? That's enough.
Um, so I have uh, not read per se, but there was a patient who came with something like Lambert-Eaton syndrome,
Okay.
but I have not read about it like
Okay.
specifically.
So I'll just mention few that you can see in your exam. So, you can dermatological acanthosis nigrans dermatomyositis. Neurological usually gets, cerebral dysfunction. Okay. Cerebral degeneration is usually seen. Hematological, you get anemia and DIC. Now, what is a paraneoplastic syndrome that's commonly seen with clear cell carcinoma of the ovary?
So I don't know.
Can anyone answer in the chat?
Hypercalcemia.
Yeah, so you can get a hypercalcemia with clear cell carcinoma of the ovary. Okay, just remember, I mean, all these are like added points. They're not very important, but if you answer really well, then the examiner can go beyond the regular framework of questions. So now at this point, I'd like to discuss here what is the importance of previous surgical intervention, like in case of CA ovary.
So if a patient comes to you with a biopsies already, it may upstage the disease if it's an early stage disease. So we
Okay.
need to know about previous surgical
Yeah.
intervention.
What are some of the surgeries that can reduce the risk of CA ovary?
Tubal ligation, sir. Tubal
Then,
ligation. Then
okay, I'll just help you out. So you're right. So main is bilateral salpingo-oophorectomy, right?
yes, sir.
That's the one. Then tubal ligation and hysterectomy, although they do not directly remove the ovaries, they can decrease the blood supply to the ovaries and reduce the risk of ovarian malignancy. Okay, so those are the three surgeries that you commonly associated with decreased risk of ovarian malignancy. Okay. Now, can we go to the next slide, please? Okay. So, what are the risk factors, comes to your menstrual and obstetric history, what are the risk factors that, increase the risk of CE ovary? What are the risk factors that you mentioned here that decrease the risk?
The risk factors that increase the risk are early menarche, late menopause, nulliparity, if the woman is not breastfed, um, HRT increases the risk, and what decrease the risk are OCP use, tubal sterilization,
Yeah.
and
So,
multiple, as in normal parity and breastfeeding
yeah.
decrease the risk.
Yeah, so all these are like, like nulliparous state, early menarche, late menopause, inadequate lactation, right? They're all, it put you at an increased risk of, breast ovarian malignancies. Whereas OCP use, it decreases the risk, uh, especially when you give combined, estrogen, progesterone, OCPs, and hormone replacement therapy. The data is conflicting. Now, can you tell me the two theories associated with development of sea ovary, the etiology of sea ovary? Do you happen to know two theories?
Yes, theories are there are precursors in the fimbriae, so Estic and Scout.
Yeah.
Is that
Okay. Okay. Like as in leading to why these risk factors cause increased risk of sea ovary. So have you heard of this incessant
yeah?
ovulation hypothesis?
Yes,
And
yes, yes,
yeah,
sir.
okay, tell me.
So incessant ovulation occurs if there's early menarche, late menopause, so there'll be incessant ovulation. So the increased ovulation, more risk of ovarian cancer as opposed to so that much I know. So that's
Yeah,
it.
so spontaneous mutation occurs during each ovulatory cycle. Okay. With repair of the
Okay.
during each ovulation, there's repair of the surface epithelium, and that leads to spontaneous mutations, which can increase the risk of ovarian malignancy. What's the gonadotrophin hypothesis?
No, I don't know about that. So.
Yeah, so that says that increased FSH and LH can increase the risk of ovarian cancer, which is why during pregnancy, like these hormones are decreased, so there's decreased risk. Okay, so those are the two hypotheses that you need to know about. It's mentioned in DaVita, incessant ovulation hypothesis and gonadotrophin hypothesis. Okay, now apart from all this, what is the biggest risk factor for ovarian malignancy?
Um, so age is directly related
Yeah,
to.
age. Okay. And we'll talk about, just to, finish this off, uh, what are the inflammatory causes or, the other gynecological causes that can lead to an increased risk of ovarian malignancy?
So PCOD, endometriosis.
And pelvic inflammatory disease, right? Yeah. Okay, so apart from that, you can also mention, infertility and obesity. Obesity, especially in premenopausal women. So all these are the risk factors, right? So let's go to the next slide. Okay, the next slide. Yeah. So what is the significance of family history in ovarian malignancies?
So the two most common things are, one is BRCA mutations,
Okay.
which have HB, breast and ovarian syndrome, and second is Lynch, HNPCC.
Okay.
Like, two are important.
Yeah, so you're right. So what percentage of ovarian malignancies are associated with the germline BRCA mutation?
With BRCA,
Germline BRCA.
germline BRCA, as in BRCA1 and BRCA2, right?
Yeah, so there's germline and somatic. Okay,
Somatic.
so
Yeah,
hereditary, the germline is associated with 15 to 20%. Okay,
15 to 20.
yeah, and Lynch syndrome. How many cases of
Uh,
ovarian malignancies are Lynch syndrome?
very less, so 4 to 5%.
It's 1 to 2%. Okay, so germline
Yes.
BRCA is around 15 to 20%, and Lynch syndrome is 1 to 2%. Okay, so that's the general incidence. Now, how do you test for germline BRCA?
We
What is the technique used and what is the sample used?
we take the blood sample and
Is it
we
so?
by NGS. Yes, we use that.
Okay, so
And
germline BRCA usually, yeah. So blood sample is also fine. You're right. Okay. You can also do what is another sample that you can do? An easier one, less invasive one.
saliva also.
Yeah, exactly. So saliva can be used. Blood sample can also be used. Your answer is right. What is the technique used?
NGS we do, but now there are different panels where only BRCA1 and BRCA2 also we are testing. So recently we are doing that,
Yeah,
but NGS has been there always.
NGS. What about large deletions?
We
So
can miss MLPA, so we need
yeah,
to
yeah.
do.
So you can say NGS plus or minus MLPA, especially if you have done NGS alone and you're still suspecting there's a strong family history, there you can add on MLPA, right? If you're still suspecting a hereditary cause. Okay, now what is the risk of ovarian malignancy in BRCA1 and BRCA2?
In BRCA1, about so 20 to 30% in BRCA2, more it is like about 40 to 50%.
Yeah, so it's the other way around actually. In BRCA1, it is
Sorry,
50%.
sorry.
In
BRCA1.
BRCA2, it is 20 to 30%. Okay,
Yes,
so BRCA1 50, BRCA2 20 to 30, right? And
yes, yes.
one more thing I'd like to ask you is, so once you have found a germline BRCA mutation in a patient without malignancy, okay, so you've screened and found a germline. Let's say it's a patient without history of malignancy. You've screened and found germline BRCA mutation. What is the timing of doing prophylactic surgery?
For BRCA1, it is slightly earlier, after 35 years, and for BRCA2, it is after 40 years,
Uh,
slightly late.
Yeah, yeah. So you're right. So when I'll just request those in the comments to comment after she finishes answering, so that she gets the opportunity, right? So yeah, please do that. So you're right. BRCA1 it is 35 to 40 years, and BRCA2 it is slightly later. So give that range, okay? 40 to 45 years. Okay, so 35 to 40 and 40 to 45, and you'll do a prophylactic bilateral salpingo-oophorectomy, right?
Yes.
Yeah. So, do you what else do you do along with prophylactic salpingo-oophorectomy?
So hysterectomy.
Yeah. Yeah. So I'll just tell you that. So when you mention prophylactic surgery for a BRCA1 or BRCA2 mutation, you need to do a bilateral salpingo-oophorectomy, and you also need to do a peritoneal cytology. You need to take biopsies. You need to inspect all the peritoneal surfaces and also take random biopsies and biopsy of suspicious areas. So along with that, you're also doing slide staging as well to rule out. So what are we trying to rule out here? These patients can present with peritoneal deposits as well. Okay. So we're trying to rule that out as well. So bilateral salpingo-oophorectomy, cytological examination of the peritoneal fluid, then examine all the peritoneal surfaces, and also take biopsies of suspicious areas. So all this has to be done when you do a risk reduction surgery. And can you say that there's 100% chance of risk reduction in CA ovary once you've done a prophylactic bilateral salpingectomy? What sort of malignancy can happen?
95 to 99% there is it's preventive for ovarian cancer.
Yeah. So 2 to 4% still there's a chance for peritoneal disease.
Yes.
Okay. So you're right. Around 95% of the cases, it prevents ovarian cancer, but 2 to 4% of the cases, there's still chance for primary peritoneal disease. So that is something that you need to tell the patients. Okay, so we have mentioned that. Now, coming to the rest of the discussion on BRCA 1 and 2, you can just watch my breast video. I think that in that everything is covered. Okay, so this is regarding BRCA 1 and 2 regarding ovarian malignancies. Now, your Lynch syndrome, right? Lynch syndrome, like ovarian malignancies are third most common malignancy. So Lynch syndrome, how do you test for the presence of Lynch syndrome?
So they are microsatellite unstable. So we look for MMR deficiency.
How do we do that?
By IHC.
Good.
We do. So if it is deficient, then to suspect. Plus, there's a strong family history, the Amsterdam criteria.
Yeah. So yeah, you have the Amsterdam criteria, you have the Bethesda criteria. We'll discuss that in some other topic. And once that is established, first you have to take the tissue specimen, right? The tissue specimen and do either IHC for deficiency in MMR can be done, or you can do PCR for MSI high status, right? So
Yes.
microsatellite instability can also be established through PCR. So either one of these two techniques are used. Once you have done that, you make sure that there's no you rule out hypermethylation of MLH1 or BRAF mutation. So once those two are ruled out, then you can do a germline testing. And if germline is also mutated, then you can say that this is a germline malignancy. So that's how you do it. First, you do with the tissue, you establish DMMR or MSI high, you rule out hypermethylation of MLH1 if MLH1 is the mutated one, right? And then you do germline testing. So usually in the blood or in the saliva, and not on the tissue, unlike the baseline testing. And there you establish whether it has a germline predisposition. So that's the stepwise testing to establish germline or hereditary Lynch syndrome. Okay. And okay, so moving on, can we move to the next slide, please? Okay, so can you summarize the case again?
A 58 years old postmenopausal lady, known case of hypertension with complaints of pain in abdomen since 3 months, associated with increased satiety and loss of appetite.
Yeah. So loss of appetite and early satiety, right? So
And
what is your differential here?
so ovarian cancer, then an ovarian malignancy, then it can be endometrial malignancy, it can be a colonic malignancy, and also a gastric malignancy. So
yeah.
all
So
these
my advice to you, when you ask when they ask you the DD after your examination, right? Sorry, after your history, mention it like this: I am suspecting a malignancy of adnexal origin. Okay. Because these symptoms are very non-specific. So you've got abdominal pain, you've got early satiety, you've got decreased appetite. So based on these symptoms, it is looking, you cannot say whether it's ovarian, whether it is a fallopian tube or any of the other adnexal structures. So just say malignancy of adnexal origin could be an ovarian malignancy if the examiner pushes you. So start off with first DD should be malignancy of adnexal origin. Okay. Second DD you can mention as GI malignancy, could be a colonic malignancy. Okay, because even certain case of CA colon can present with these sort of symptoms. Uterine malignancy seems unlikely. You need not mention that. Okay, so just give your first DD as malignancy of adnexal origin. If they push you further, say it could be of ovarian origin most commonly. And second is a GI malignancy with the symptoms could be a colon malignancy. Although, so they'll ask you then, how can you defend a DD of malignancy of adnexal origin?
Because it's a postmenopausal female, ovarian cancer is more commoner.
Yeah, what is the incidence of ovarian malignancy worldwide
It's
and in India per 1 lakh patients?
6 per lakh patients.
Yeah. So around there. So worldwide it is around 17.6 lakh, and in India it is around 7 cases per lakh population. So what is amongst women, which rank does ovarian malignancies have?
The third rank, sir.
Yeah, so it is third most common malignancy amongst women in India, with an incidence of 7 per 1 lakh population. Okay, so that you're right. So the age, the postmenopausal status, all these go in favor, right? The incidence in the general population goes in favor. This is the third most common malignancy. Um, then, of course, the symptomatology. There is no associated GI symptoms, right?
Yes.
To put us in favor of a GI malignancy. So it is non-specific symptoms like lower abdominal pain. So it fits in with an adnexal mass. There's no associated GI symptoms, right? And there's early satiety, decreased appetite. So all these things go more towards an adnexal mass. Then, of course, the short history. So, like we mentioned in our GOF symptom index, you have persistent symptoms that are lasting greater than 12 times a month for less than 1 year, right? So it fits into that criteria as well. So based on that, you can say that. Okay. So number one DD is adnexal origin malignancy. Second is a GI malignancy, could be a colonic malignancy. Or if they push you further, you can see a GI malignancy with Krukenberg mets. So those are the things that you can sort of pinpoint at, right? You need not go on and on with your. So another tip I'd like to give is don't just mention 1 or 2 DDs and stop it there. Unless the examiner when the examiner asks you to defend your DD, mention the points that I mentioned, right? So malignancy of adnexal origin, age greater than 60 years, postmenopausal lady, incidence is very high, third most common malignancy, symptomatology of non-specific symptoms, lower abdominal pain, right, with no GI symptoms, then short history of less than 1 year. So all these features can point towards an ovarian malignancy or an adnexal origin malignancy. GI malignancy seems less likely because of the lack of GI symptoms, although this colonic malignancies can also present with lower abdominal pain, or you could have Krukenberg mets from a GI malignancy. So GI malignancy just you can only mention when the examiner presses you. So don't put scenarios in front of the examiner, right? Mention the main scenario. If they push you, then you can mention GI malignancies, either CA colon or another GI malignancy with Krukenberg mets. So only mention that if the examiner pushes you. Okay. Okay. So I hope you understood that. You can move on. You can proceed.
On general physical examination, after obtaining consent, she was examined in a well-lit lit room. ECOG PS1, conscious oriented, vitals are stable, height 156 centimeter, weight 62 kgs, BAC 1.6, BMI 25, no pallor icterus, pedal edema, no supraclavian lymph nodes, inguinal lymph nodes. Systemic examination after consent with a female chaperone exposed. She was exposed from nipples to mid-thigh, examined in supine and sitting position. Abdomen appears distended. Fullness in lower quadrant of the abdomen. Umbilicus is central. Skin over abdomen is normal. No scars, sinuses, dilated veins. Respective quadrants move equally with respiration. No visible pulsations, peristalsis. External genitalia are normal. Hernial sites appear normal. Palpation. No rise in temperature, no tenderness, no guarding. Abdominal girth is 75 centimeter. A 10 into 10 centimeter mass is felt in the hypogastric region, extending to the left iliac umbilical region and extending till the midline. Smooth surface, firm consistency, ill-defined borders and restricted mobility. Lower extent of the lump not felt. Upper extent felt just below the umbilicus. No other masses felt. No palpable organomegaly, no cuff impulse at hernial sites. Percussion, dull note is felt over the mass, no shifting dullness. Liver span is 13 centimeter. Auscultation, normal bowel sounds are heard. Genital examination, external genitalia are healthy. Urethral surface is normal. Post speculum, vagina cervix is healthy. No mass lesion, no bleeding, no discharge. Per vaginal examination, no mass bleeding, discharge. On bimanual palpation, mass felt in the left adnexa. Per rectal, there's no nodularity mass, no nodularity or mass in the pouch of Douglas. Rest of the systems examination is normal. To summarize, a 58 years old lady, known case of hypertension, postmenopausal with complaints of pain in abdomen since 3 months, associated with loss of appetite, increased satiety. On per abdomen examination, was found to have a mass occupying the left iliac fossa and hypogastrium. Per vaginal examination, by manual palpation, adnexal mass felt in the left adnexa. Bilateral fornices are free.
Okay, so after this, what would your diagnosis be? How will you change your DD? Would you like to keep both your DDs, or like?
Only ovarian malignancy, so.
Okay, so at this point, you can, yeah, like you said, you can probably say that we are dealing with,
Adnex.
yeah. So earlier we said an adnexal mass, right? So here we
Yes.
can probably say that it's a malignancy of the adnexa, most probably an ovarian malignancy. Okay. So here we can, go a little beyond the adnexal mass and say that it is an ovarian mass. So what are the features in your examination that were in favor of an ovarian or adnexal origin mass?
So one that we could not feel the lower border. So
Yeah, very
it was
good.
abdominal pelvic mass. Second, that's on bimanual palpation, the adnexal mass was felt in the left adnexa.
Yeah, so those are the two most important points. First of all, it's a lower abdominal origin. It's located in the lower abdominal quadrants, right? Uh,
Yes.
so in the iliac fossa and the hypogastric region. So that itself shows that it could be of adnexal origin. Second thing is the lower border is not felt, right? And another thing is that on bimanual palpation, found you found that it is of adnexal origin and it is separate from the uterus, right?
Yes,
So,
sir.
so there you can probably say that it is a ovarian malignancy or adnexal malignancy, most probably an ovarian malignancy, based on these features. Now,
Yes.
another thing is based on this, you can rule out that it is of GI cause, of this thing, colonic origin as well, right? Because there you might feel the lower border. You won't bimanual palpation. You won't feel an increase in size of the adnexa. How do you do bimanual palpation, by the way?
So we put we use 2 fingers. We put it through the vagina from below after giving position to the female, and the other hand is up on the abdomen.
In what
So,
area? In what quadrant?
so lower abdomen.
Yeah, so what you do is, suppose it's a right adnexal mass, you use one hand and you palpate the right iliac fossa, right? And with the
Yes.
other 2 fingers, you go per vaginal, you go to the right lateral fornix, and you try to approximate the hand and the 2 fingers inside the vagina. Okay, inside the fornix and the hand that is kept in the right iliac fossa. And if you're able to approximate it, there might not be an adnexal mass. But if you're not able to approximate it, then that could signify that it is an adnexal mass. And you can also palpate the lateral border of the uterus as well. And so you can see that it is separate from the uterus. So that's how you do a bimanual palpation. It is very important usually when you do when you encounter a CE ovary case. Now, another symptom, although in this patient it was not there, is ascites, right? So what are
Yes.
the 3 signs associated with ascites?
Shifting dullness, then
It's seen for how much, so fluid thrill, right? You start off with fluid thrill.
fluid. Yes.
How much should be the liquid, the content for you to detect that?
Yes. So 1.5 to 2 liters.
Okay, yeah. Then shifting dullness.
Shifting dullness, the fluid should be 500 to 1000.
Yeah, you're right. 500 ml or so, right?
Yes.
And what is the third sign?
Horseshoe dullness,
Uh, uh, puddle sign.
puddle sign. Yes,
Yeah. Can you
that's a
tell me
very
how you
common.
elicit the puddle sign?
So the patient is uh, made to sit in the prone position, with his knees and hands touching down, and so I don't remember
Yeah. So
properly.
you
But
first you settle the patient down in prone position for a few minutes, and then you ask them to rise and lie down in the knee elbow position. Okay. And then you use your stethoscope, and you tap slightly, and you start moving the stethoscope from the central, the most dependent position, to laterally. Okay. And there's a change in the auscultatory sound, right?
Yes.
Then it shows that there is ascites that has collected in the most dependent position. Okay.
Yes.
So just read up on a puddle sign. Now,
Yes.
what is the difference? How will you differentiate on examination between omental caking versus pelvic mass?
Um, Caking will have so the consistency will be different. So cake
Okay.
like
Yeah,
mental.
I mean, it could be softer versus less, less firm than a pelvic mass. But the main thing is, once again, you cannot go below the mass, so can't get below, and it is not felt on, it is not palpated to be an abdominal mass on bimanual, as a adnexal mass on bimanual palpation. Okay, so bimanual
Yes.
palpation and not able to go below the mass are the two ways in which you can rule out omental caking. Okay, now can you tell me how will you differentiate a retroperitoneal mass? Okay, since we're on the topic of abdominal examination, right? How do you differentiate although this is not that relevant to CA ovary, but how do you differentiate a retroperitoneal mass from an intra-abdominal mass?
So it moves with so the retroperitoneal mass does not move with respiration. The intra-abdominal mass will move up and down with respiration as the diaphragm goes up and down. Then when the abdomen is made tense by leg raising or raising your head above, so that time the intra-abdominal mass will become more prominent. So
Okay, so this the best thing is, once again, the knee elbow test. Okay, so
okay.
if the mass is palpable, once you ask the patient to go and bend forward in the knee elbow position, if it's a retroperitoneal mass, it will become less prominent, and if it's an intra-abdominal mass, it will become more prominent. Now, the leg raise test that you mentioned is to differentiate an intra-abdominal mass from an abdominal wall mass. Okay, so once you raise the legs, the abdominal wall mass will become more prominent, whereas an intra-abdominal mass won't stand out that much. So because the abdominal wall muscles are tensed, right?
Yes,
So
sir.
leg raise test is to differentiate between abdominal wall versus intra-abdominal, whereas knee elbow test is used to differentiate between retroperitoneal versus uh, intra-abdominal. Okay, so just 2 points regarding abdominal examination uh,
Yes.
that they can ask you. Okay, now so we have completed our history and examination. We have given the DDs. Okay, so post history we gave a DD of malignancy of the adnexa, and second was a GI malignancy, could be a colonic malignancy due to the location of abdominal pain, or could be Krukenberg Mets from a primary GI malignancy. Then we have done our examination, and we have said that it is a adnexal malignancy, most commonly an ovarian malignancy, right? It's based on our
Yes.
examination findings. So now, what are the other questions that they can ask you in this area? Okay, what is the ratio of benign to malignant ovarian tumors?
It's a ratio.
Yeah, so it is 80 to 20. Okay. 80% are
Okay.
malignant, 80% are benign and 20% are malignant. Can you name some benign causes of adnexal mass?
So in younger females, it can be functional cysts or hemorrhagic cysts, tubo-ovarian abscesses. Uh, then it can be endometriosis. Then cystadenoma, adenofibromas, then
Yeah.
fibromas.
Yeah, so you're right. So you can start off with the fallopian tube, paratubal cysts, hydrosalpinx, tubo ovarian abscesses, ectopic pregnancies, tubal neoplasms. Then ovary can be an endometriotic cyst. It can be PCOS. It can be a functional cyst. It can be a serous, mucinous, or endometrioid or clear cell cystadenoma. Right. So those are the
Yes.
commonly seen benign causes. Now, when you come to the classification of ovarian malignancies, can you classify ovarian tumors?
Epithelial ovarian tumors, sex cord stromal tumors, and germ cell tumors. Then
Within epithelial?
Yes, sir. Within epithelial, there's serous. So serous can be benign, borderline, and malignant. Serous
Okay.
carcinoma. Then clear cell again can be benign, borderline, and malignant. Then mucinous tumors again they can be same, and Brenner tumor uh, and clear cell
Yeah.
ovarian tumor.
Yeah. Okay, so I'll just you're right. So I'll just quickly mention it. The most commonly seen is epithelial malignancies. Okay, around 90%, and within that, most commonly seen is serous, around 70%. Okay, so serous can be, like you said, it can be malignant, it can be borderline, and it can be benign, usually in the form of cystadenoma. Then you have clear cell, endometrioid, and mucinous, all of which can also be malignant, borderline, or in a benign cyst, in the form of a benign cyst. You also have Brenner's tumors, which are also uh, borderline, benign, or malignant, right? So epithelial is most common, 90%. Inside that, most common 70% is serous, 10% is clear cell, 10% is endometrioid, and mucinous is less than 5%. So that's the classification. And all of this can vary from benign to malignant. Then you have GCTs, which is around 5% of the tumors. And GCTs are usually seen in younger patients, right? And
Yes.
they're teratoma, dysgerminoma, yolk sac, embryonal and choriocarcinoma. Then you have your sex cord tumors. Sex cord tumors are your GCT, thecoma, fibroma, Sertoli, Leydig cells. And then you have other miscellaneous tumors, including metastatic lesions. Okay, so now coming to, I'll just ask you some questions that are commonly asked. What is MEG syndrome?
Mix syndrome is a benign ovarian mass fibroma with ascites and pleural effusion.
Okay, what is pseudo-MEG syndrome?
Other than a benign mass, other than a fibroma, commonly it is seen with dysgerminoma, sir.
Yeah, so the same with leiomyosarcoma, teratoma, and it could even be a malignant lesion. Okay, okay. So non-fibromatous mass, right? Non-fibroma mass.
Non-fibroma.
That causes ascites and hydrothorax. What is pseudo-mix syndrome?
So I don't know
Yeah.
pseudo.
So it's ascites pleural effusion with a falsely raised CA-125 seen in SLE actually.
Okay, sir.
Okay. So suppose what ovarian tumor is seen with raised thyroid hormones.
HCG secreting tumors, choriocarcinoma, sir.
Okay, that's falsely raised, but actually, yeah. So choriocarcinomas can increase, secrete beta HCG, which can mimic TSH. But there's something called struma ovary, right?
Tumor, yes,
Yeah.
sir.
So that secretes thyroid hormone. It is actually a teratoma with thyroid tissue, actually.
Thyroid, yes.
Okay. So in that case, you can secrete thyroid hormone. So we mentioned that Krukenberg tumors, right?
Yes,
So
sir.
earlier in our post-history DD, we had mentioned that it could be adnexal malignancy, it could be a GI malignancy, either CA colon, or it could be another GI malignancy with Krukenberg tumors. So what is how do you differentiate between a Krukenberg versus primary?
Krukenberg tumors are often bilateral.
Okay.
A primary may be unilateral. Then a primary tumor is usually larger, maybe more than 10 to 12 centimeter. Krukenberg may be smaller. Then the surface is usually smoother in Krukenbergs, while in the ovary it is disrupted surface is there. Then you differentiate on the basis of the histology. So usually ovarian has a precursor ovarian pathology, while Krukenberg will have a GI pathology. And
What about on the markers?
uh, uh, so IHC markers, sir.
No, not IHC, the
Tumor
serum
mark. Uh,
tumor markers, yeah.
tumor markers, CA-125 will be raised, and the ratio of CA-125 by CAA will be more than 25 if it is an ovarian primary.
Yeah, so the CA to CA 125 ratio will be greater than 25. Like you said, most common it is bilateral. It's got a smooth surface and it is capsulated. And of course, it is associated with a GI malignancy. So you'll get GI symptoms, etc., that are seen with Krukenberg tumors. Or rarely you can get a breast lump. Okay, so usually you differentiate with the ratio. A
Yes.
CA 125 ratio is greater than 25. It goes more in favor of Krukenberg. Okay. and it is bilateral with a smooth surface associated with a GI malignancy. So GI symptoms can also be there. And on scopies, you can also find a GI malignancy. So that's how you differentiate both. Okay, how will you differentiate epithelial ovarian malignancies and GCTs based on the age and the stage?
So the epithelial ovarian cancers are mostly after 45 years. They steep up the
Yeah.
incidence.
So you're right. So not 40, but fifth and sixth decade. Okay. They're slightly old. So postmenopausal usually. And GCTs are in young. So in 20 to 40 years, you'll see those. Okay. And like we said, the acute presentation is rare in EOC, epithelial ovarian malignancies, whereas GCT, it's more common. Like you can get torsion, you can get hemorrhage, and all of that.
Yes.
And the stage is also different. So epithelial usually presents in advanced stage, whereas GCT is usually in the early stage. Okay. Okay. Now, moving on. So we have got this patient, and so how will you evaluate this patient?
So first,
Very quickly, you can tell me how will you evaluate this patient? What are the steps you do?
I'll
So
do an
I'll
image.
like, just for everyone's sake, I like to say we evaluate the patient when you do the workup under three headings: workup for diagnosis, workup for staging, and workup for treatment. Sometimes you have to combine workup for diagnosis and staging, but yeah, that's a general format. So yeah, please proceed.
For diagnosis, I'll first start with an USG abdomen pelvis. Then I'll find suspicion of ovarian malignancy. Then I'll further go and do a CT abdomen pelvis and CECT chest for staging. And
For
then
USG, is there something else you would do?
tumor markers I will do, sir.
Yeah, so number one, you start off with the tumor markers. Okay. What are
Yes.
the two tumor markers you'll do?
CA-125 and CEA.
Yeah. Then you do your ultrasound, right, of the abdomen
Yes.
and pelvis. And then you
Yes.
do?
Then we do CCT chest and CT abdomen pelvis.
Okay.
Then for evaluation, sir, for the CBCRFT, LFT
Okay.
serology.
So yeah, so in the initial staging, I'll just tell you. So what we do is we do a CA-125 and CEA, right? Along with the, you can also do the blood tests and viral markers at that point. And then uh, you do an ultrasound of the abdomen and pelvis, right, to look for malignant features in your adnexal mass. And after that, you do a CT thorax, abdomen, and pelvis, right, to look at the stage of the disease, right?
Yes.
You cannot stage an ovarian mass based on imaging, but you can get an idea of whether it is local or whether it is advanced, right? So you can get all those features in a CT thorax, abdomen, pelvis. So that's the third step. The next step is some people might also do a laparoscopy if they're suspecting, if they're not able to, look at the degree of peritoneal mets based on CT alone, right? Because that might not always be visible on the CT. So you can also do a diagnostic laparoscopy to look at the degree of peritoneal mets. So once you have done that, the next step you need to mention is discuss in an MDT. Okay. Discuss in an MDT to decide for resectability. Okay.
Yes.
So once you decide whether it is resectable or unresectable. So we will discuss first the scenario we'll discuss is unresectable. Okay. So if it is unresectable, that's when you go for a biopsy. Okay.
Yes.
So site of the biopsy is from the most accessible lesion. You will not do it from an ovarian primary or anything. You don't want to rupture the cyst and cause, also to upstage the disease, increase the peritoneal mets, cause discomfort to the patient. So do it from an accessible site. There you'll do the biopsy, right? And so that is in an unresectable case, that is how you work up the patient. Workup and staging of the diagnosis and staging of the patient is done like that. So you do a CA-125 CEA, basic blood test, viral markers. You do a ultrasound abdomen pelvis to characterize adnexal mass. Then you do a CT thorax, abdomen and pelvis. You can also couple that with a diagnostic laparoscopy to give extra additional information on the peritoneal status. Then you discuss an MDT and get everyone's opinion with the gynec oncology people, the surgical oncologists, etc. And you get an opinion on whether it is resectable. And then following that, if it is unresectable, which is the scenario we're discussing now, then you do a biopsy. You do it from the most accessible site, which will cause least discomfort to the patient, right? So you do it from one of the peritoneal mets, for example. If there's a cytic fluid, you can set that for cytology and cell block as well. Although the sensitivity is much lesser. So that's how you do the initial workup for diagnosis and staging in an unresectable case. Now let us go through all those components, right? There are a lot of questions that they can ask you when it comes to all this. So this CA-125, right? What is the American College of Obstetrics and Gynecology? What is the cutoff they have given for significant CA-125 in case of a pelvic mass for premenopausal and postmenopausal?
So for postmenopausal, it is 35 units per ml, and for premenopausal, more than 200.
Yeah, you're right. So that is the cutoff given. And what are the conditions in which you can get a raised CA-125? Benign conditions.
So multiple conditions such as a simple ovulation also, then otherwise abdominal TB, endometriosis, then uh, like anything involving the
Yeah,
epithelial.
you're right. So, TB, pelvic inflammatory disease, endometriosis, liver disease, fibroids, all these you can get a raised CA-125. Malignant, it's ovarian cancer and
Um,
endometrial cancer as well.
endometrial.
Yeah. Okay. So
Endometrial.
this CA-125, it is so something you need to know about it is that it is most commonly associated with serous ovarian cancers. It can be elevated in other subtypes like mucinous, clear cell, endometrioid, but it is only elevated in the advanced stages. Okay. And it is not due to the cancer as such in those subtypes. It is due to the involvement of multiple structures, right? Intrapelvic and intra-abdominal structures. So that's what elevates it rather than the cancer itself. Serous is associated with CA-125. In other ones, it can also be seen in advanced stages due to involvement of other pelvic structures. So that is something you need to know, that it can be raised in all subtypes, but mostly it is seen in serous in both early as well as advanced, right? And 75% of serous cases have it. In all subtypes, it can be seen in advanced when multiple structures are involved. What about CEA? Which subtype is it seen in?
So mucinous.
Yeah, so pretty much the mucinous subtype is where you get a rise in serum CEA. So what is the role of using CA-125 for screening? Is there any data to back it up? Whether it's positive or negative for screen?
It's the negative
Yeah,
trials.
okay. The trial was?
So PLCO, then UKC talks, SC SOX, Japanese trials.
Yeah,
For
so
the
primarily you can see the PLCO trial. They used transvaginal ultrasound and CA-125, and there was no mortality benefit of, diagnosing it early, right? The
yes.
main drawback with CA-125 was that for the very early ovarian tumors, there was no increase in CA-125 that was seen. So that is the main drawback. That is why the trial was negative, the PCLO trial. PLCO trial, sorry. So what are the uses of CA-125 in a case
So
of ovarian malignancy?
it can be used for diagnosis, then it can be used to for follow-up, for response to treatment, and then for follow-up it can be used. Also to differentiate between the mucinous, the CA-125 ratio we saw, the mucinous and the epithelial serous carcinomas.
Yeah, so whether the pelvic mass is malignant, right? You can
Yes.
see that.
Yes.
If the origin is unknown to go towards an ovarian origin, you can use that to assess response during treatment, post-treatment surveillance, and there is also one indication of screening of ovarian cancer. Okay, so like I said earlier, in general population, screening does not, give us any benefit, does not decrease the mortality. But you can consider screening of ovarian cancer in high-risk population. Okay, so that has been attempted successfully. That is using the ROCA protocol. Okay.
Yes.
Risk of ovarian cancer algorithm. Okay, so that's been used in high risk populations such as this BRCA1 and BRCA2 mutated patients. Okay, so
Yeah.
that has been successfully tried. So those are the uses of CA-125. Right, now moving on. So now we, like that was the first test, CA-125, CEA. Next, we are doing an ultrasound abdomen and pelvis, right? So can you tell me what risk of malignancy index score is?
Risk of malignancy index uses the USG findings plus CA-125 25 and the menopausal status of the female.
Yeah. So what are the high-risk features that you'll see on ultrasound that suggest malignancy?
The solid cystic lesion, complex cystic lesion with multiple, more than 4 papillary projections, thick septae which are about more than 2 mm. Then there is multiloculated tumors. Then apart from the then increased vascularity of the tumor, of the lesion.
Yeah.
Apart from that, ascites deposits, peritoneal deposits.
Yeah. So basically there are various risk techniques based on our ultrasound imaging. You have the risk of malignancy index, uh, and the IOTA, the IOTA, International Ovarian Tumor Analysis Index. Okay, so those are the most commonly used indexes. Risk of malignancy index combines the ultrasound score into the menopausal status into the CA-125 status. Okay, so the ultrasound score is based on multiloculated cyst, solid cyst, bilateral cyst, presence of ascites, presence of intra-abdominal mets. So all of this is assigned a score of 1. And if you have, so all of this, so if you have 0 to 1 features, a score of 1 is given. If you have 2 or more features, a score of 3 is given. Okay, so that is the ultrasound score. If you have 0 or 1 of these features that I mentioned, a score of 1 is given. If you have two or more features, a score of 3 is given. Next is the menopausal status. If you have postmenopausal status, score of 3 is given. If you have premenopausal status, score of 1 is given. And next is the CA-125 level. So you multiply all of this, and if the score is greater than 200, there's a high risk for malignancy. Next is the International Ovarian Tumor Analysis, IOTA index, right? So there you have malignant features and benign features. So M features and B features. M features include irregular solid lesion, ascites, greater than 4 or more papillary structures, multiloculated, largest diameter of the tumor should be greater than 100 millimeter, and it should be hypervascular. The benign features include unilocular, solid, but the solid component is less than 7 millimeter, presence of acoustic shadows, no blood flow, and largest diameter is less than 100 millimeter. So all of this goes for benign. So based on the ratio of malignant and benign features, you can see whether it is look at the risk for malignancy. Okay, now of course you've got an adnexal mass. What are some of the other tools you can use? Although this is not that important, what are some of the other tools you can use in terms of blood tests to see whether it is malignant that you know of?
OVA1 and OVA2 are there.
Yeah.
OVA1 has CA-125, HE4, transferritin, transthyretin, and beta-2 microglobulin, while OVA2 has um, FSH, it has CA-125, apolipoprotein, and
Yeah. So you're right. So see, OVA1 has CA-125, apolipoprotein, beta-2 microglobulin, transferrin, and prealbumin, and a score of greater than 5 is considered in premenopausal to be significant. Score of greater than 4.4 is considered to be significant in postmenopausal. OVA2, what they did was they kept CA-125, apolipoprotein, and transferrin, but they replaced beta-2 microglobulin and prealbumin with FSH and human epidermal protein 4. Okay, so OVA2 contains CA-125, FSH, human epidermal protein 4, apolipoprotein, and transferrin. Then there's also the risk of malignancy algorithm, the ROMA criteria. So that is CA-125 plus human epidermal protein 4 only. Okay, so those are the other things that you can look to see whether an adnexal mass is malignant or not. So you have done a CA-125 CEA, you've done an ultrasound abdomen and pelvis, you do your CT thorax, abdomen, and pelvis to see the extent of the disease, to get an idea of the extent of the disease. Okay, so in endometrioid, something to note here is that you'll get less caking, you'll get less ascites, you'll get less omental mets, and it might also be associated with a uterine mass. Okay, so that's the difference between serous and endometrioid. Less caking, less ascites, less omental mets may be associated with a uterine mass in 10% of the cases. In clear cell, clear cell carcinomas, the imaging is slightly different. Here, the adnexal mass is more cystic. It is unilocular. There's a higher chance for unilocular mass, and it can have solid protrusions right? So cystic, unilocular with solid protrusions can be seen in the adnexal mass in a clear cell carcinoma of the ovary, which is different from serous and endometrioid. So that's also something to keep in mind. If this was, so then you do your CT, also you combine with laparoscopy for peritoneal mets. Is there something else you do on a mucinous carcinoma?
Yes.
Yeah.
Yes. Colonoscopy and upper GI scopy for.
Yeah, so it is like a given. Without a doubt, you need to do upper GI, you need to do colonoscopy if you get a mucinous histology, because there's a high chance that you might have an associated GI malignancy, right? Okay,
Yes.
so can you give me some named criterias for resectability, to assess resectability?
Yes, sir. Uh, if disease when it is not resectable, these points are there. That is involvement of the porta hepatis, SMA, route of mesentery, extensive upper abdominal disease, parenchymal metastasis, bowel involvement, or that will cause resection of a significant amount of bowel, uh, and extensive ascites,
Yeah. So
extensive.
you mentioned some of them, you're right. So I'll just tell you. So when they ask you for criteria for, can you name some criteria for resectabilities? You can say the Leuven's criteria, the Bristow criteria. Someone mentioned Nelson's criteria. All these are criteria that have been used. There's also a laparoscopic criteria called Fagotti's criteria. So those are the based on the disease involvement, the criteria for unresectability, right? And of course, you might have the patient's condition, like poor GC, they might not be amenable to upfront resection. So if they ask you, can you name some of the what do you call it? The the conditions where the patient might be inoperable. So name the criteria. You need not study each criteria in detail. It is too much. That is more towards for surgical oncology. But you should be able to name the criteria used, and then you should also be able to name some of the common points where it is considered to be unresectable. So if you have diffuse carcinomatosis of the small bowel, involving large parts of the small bowel, where post resection there will be short bowel syndrome. So the remaining bowel will be less than 15 uh, centimeters post resection. So there's diffuse involvement of small bowel causing that might lead to short bowel syndrome post resection. That is one criteria for inoperability. Diffuse infiltration of the root of mesentery, diffuse infiltration of the stomach, duodenum, head, and middle part of diffuse infiltration of the stomach, the duodenum, the pancreas, multi-segmented liver mets, right? Where it might be difficult to, multi-lobular or multi-segmented liver mets, involvement of the celiac artery, the hepatic artery, the superior mesenteric artery, etc. Non-resectable lymph node mets, multiple lung mets are involved. If you have brain metastasis, which is very rare, then peritoneal carcinomatus. So if you have a PCI index, peritoneal carcinomatus index of greater than 20, if you have diffuse diaphragmatic involvement, if you have extensive omental caking, so all these are features where you might not be able to operate, you might not be able to do something called a primary cytoreduction, right? So you just need to know some of those features. If you can name like more than 5, the examiner will stop you and ask you, move on to the next question. Okay. So here I'd like to ask you a question. What is PCI index?
So I don't remember exactly. So
Yeah, I'll just tell you. Okay, so it is you have it combines two components: the lesion size for a score of 0 to 3, as well as the tumor distribution. So that is also given a score of 0 to 12. So it is divided into 12 regions, right? That can be involved from 0 to 12. So total of 13 regions, right? From 0 to 12, and lesion size is also taken into account. So lesion size is scored from 0 to 3. So 0 is no tumor seen, 1 is up to 0.5 centimeter, 2 is up to 5 centimeter, 3 is greater than 5 centimeter. So you add up the lesion size score for each region, and you give a score of 0 to 39. So the PCI index is 20 or more. It is one of the criteria for unresectability. Okay. So now you have done your biopsy, you have established your histology. But I would like to ask you if you, how can you differentiate the ovarian malignancies based on IHC?
yes, sir.
So we'll
So
start off with serous first.
Series will show epithelial marker CK7, that is for that is there, and then PAX8 WT1 TP53 will be mutant in Series.
Yeah, good.
And yes, sir.
In all serous or in high-grade serous, right?
High-grade serous carcinomas.
Yeah.
High-grade serous. Then in borderline serous and low-grade serous carcinomas, they will be mostly ERPR positive and P53 wild type, while Pax8 and WT1 can be positive, sir.
Yeah, good. You're right. The endometrioid?
Endometrioid, so Vimentin will be.
Yeah, I'll just help you out there. So CK7 once again is positive. I'll just quickly go through it. You're absolutely right about serous, right? So
Yes.
high grade serous, you get CK7 positivity, CK20 negative, PAX8 and WT1. P53 is mutated, especially in high grade, right? That is a marker of high grade serous. Low grade serous, P53 is wild, and in around 20 to 30%, you can see ERPR positivity, right? In case of endometrioid, CK7 is positive, CK20 is negative once again. Endometrioid, there's a high chance for hormone positivity. Pax8 is positive, but WT1 is only positive in 10 to 15% of cases. In endometrioid, P53 is wild, unlike serous, high grade. Then mucinous, so unlike the other types, mucinous has CK20 positive, CK7 negative. Okay, so CK7 could be negative. It's a reverse actually. Just like colonic malignancy, CK20 is positive. CDX2 and SADB2 can also be positive. So that's how you differentiate mucinous. Then clear cell is CK7 is positive. CK20 can also be positive here in clear cell. PAX8 is positive, but WT1 is negative. Okay, hormone receptor is negative. But interesting about clear cell is napsin A is positive and P53 is mutated. So, I mean, just write it down for each site, like I've mentioned. And, just if the exam, this has been asked in various online, practical exam sessions. So differentiating via the IHC. So just remember that. Okay. For
Yes.
endometrioid, high-grade serous, mucinous, and clear cell.
Yes.
I hope you all got that. So now moving on, next is workup for treatment, right? So in this particular patient, they've been deemed to be unresectable, say, okay, in the MDT. So now we go out for workup for treatment. What all will we do?
It's the routine blood investigation, serology. We do a 2D echo also, and so
Okay, yeah. So we can do your CBC, LFT, RFT, electrolytes. If for your chemotherapy, a 2D echo might or might not be required because we're not giving any cardiotoxic, chemotherapy agents as such. So it's not really required. If you're giving bevacizumab, you can do a baseline BP. You can do urine protein and thyroid function test. If you're planning on adding bevacizumab to your chemotherapy, if not already done, you can also do a myriad testing, a myriad foundation testing, which combines BRCA plus HRD status on the tissue. Okay, so tissue can be sent for myriad testing, which looks at BRCA and homologous recombination deficiency status. Okay, so if the score is greater than or equal to 42, or if BRCA mutation is positive from the tissue, then that has treatment implications that we'll come to later on. You can also send a separate germline BRCA mutation. Why is that important? Because sometimes the tissue BRCA mutation might be negative. Most of the time it is contrary. If your tissue BRCA mutation is negative, definitely germline will be negative. But sometimes it has been seen that tissue BRCA is negative, but germline turns out to be positive. So you always ideally should send a germline BRCA separately, along with the combined BRCA and HRD testing from the tissue. So germline BRCA from saliva or blood, tissue, BRCA, and HRD testing should also be done. And basic CBC bio and urine protein and thyroid function test and baseline BP if you're giving bevacizumab, right? So suppose a patient has borderline resectability, right? Why would you go for neoadjuvant treatment rather than going for, suppose some surgeon out there says, no, I will resect, it'll be slightly difficult, but I'll resect this patient. But still, why do we advocate, why do you have these criteria for unresectability? Like, what is the advantage of giving NACT in these cases?
for optimal cytoreduction, so which is considered R0 as of now, but which is complete cytoreduction or at least less than 1 centimeter. So that is prognostic.
Yeah, yeah. So you have a URTC trial actually that looked at doing, in these borderline cases with criteria that are met for unresectability. If you do upfront surgery versus if you do interval cytoreduction. What is the difference? So the OS and the PFS was the same, but if you gave NACT, there was higher chance for complete cytoreduction. There was less post-operative complications, including stoma bag need, wound healing, infection, and hospital stay. So all of this was decreased. The morbidity was decreased, and the uh, extent of resection was better when you gave NACT in these cases, right? And that is based on an EORCT trial. This is something that the examiner will definitely ask as to why you're giving NACT. Why can't you just go for extensive upfront cytoreduction? So those are the reasons why. And we have trial data for that. Even the outcomes are the same, but morbidity and completeness of resection is much better with post NACT in these unresectable where criteria for unresectability is met. Right. So that is why we have those criteria to decide, So NACT. Okay, what is the NACT agent of regimen of choice?
Paclitaxel carboplatin is the regimen of choice.
Okay, so can you describe how you'll give this regimen?
Yes, sir. So
With all the pre-medications, with the regimen,
yes,
post-medications, everything.
yes, sir. So I am giving aprepitant for this patient because carboplatin can be emetogenic. So injection for aprepitant 150 mg into 50 ml NS over 1 hour. Then injection Granicet 1 mg plus Dexa 8 mg in 15 ml NS in over 30 minutes. And after that, I'll start with paclitaxel. Paclitaxel 175 mg per meter square in in 500 ml NS over 3 hours in a glass bottle with a codon set with an inline filter of 2 mm is given over 3 hours. And carboplatin AUC 6 or 5 in 250 ml of D5 over 1 hour is given. And then I'll give NS for hydration.
Yeah, and post-chemotherapy?
Post-chemotherapy, so we usually give pantoprazole, Domstal, TDS, olanzapine may or may not be given, depends.
Okay, so I'll just refine that. Okay.
Yes,
So the answer I like to say, this is not a highly emetogenic regimen. Okay. So
yes,
we need not give level 4 anti-emesis. So olanzapine comes into level 4. Okay. So
yes.
this is a moderately emetogenic regimen. So we need only give level 3 anti-emesis cover. So when they ask you, can you tell me how to prescribe this regimen? Right? This is how you should answer. Uh, so I'd like to give paclitaxel and carboplatin 3 weekly for 3 cycles as my neoadjuvant treatment. Paclitaxel, before giving that, I'd like to give the pre-medications for paclitaxel, Dexa 20 mg orally at 12 hours, and I would like to give it 6 hours prior to paclitaxel. Okay. Then coming to the, so Dexa 20 mg oral should be given 12 hours and 6 hours before. Then the pre-medications include, you can give Dexa 8 mg, ondansetron, you should add Avil and Rantac, right? Anti-H1 and anti-H2 antagonists should be added.
Yes.
And you can also add fosaprepitant because you're giving AUC carboplatin over AUC 4 and above. So there you can give NK1 antagonist. So ondansetron, dexamethasone, Rantac, Avil, and fosaprepitant or aprepitant. Then you give your paclitaxel. You have said it perfectly. You give it 175 milligram per meter square. Over 3 hours in a glass bottle with a cordon set with 0.2 micron filter, right? What is the preservative used in paclitaxel?
It's a cremaphor.
Yeah, cremaphor real. So that's what we are trying to filter out with the cordon set, right?
Yes.
And why are we not using, we mentioned this before, why are we not using a PVC bottle?
Because um,
Yeah, because it can cause plasticize, leaching of the
yes,
plasticize. That is DHP, right? Primarily can
yes.
be leach. It can cause increased hypersensitivity. Okay. Suppose the patient develops severe hypersensitivity on paclitaxel. Suppose the patient has tachycardia, the patient complains of dyspnea, but saturation has not fallen, BP has not fallen. So what will you do in that scenario?
We give Avil hydrocot, give O2 supply, top up for some time, and see the vitals. So that
Okay.
perfect.
Then how do we
Perfect.
recharge paclitaxel?
Yes, sir. So, so we add PCM sometimes before the
Yeah.
next
So,
cycle.
so what we do, suppose the patient has been stopped temporarily. Now the vitals have all come down, it's all normal. Then you restart
Low,
at a lower rate. Okay. So you
lower
start
rate.
off at 10% rate for 15 minutes. Then you slowly increase to 25% of the normal rate for next 15 minutes. Then if no problems, you go back to the original rate. Okay. So you start off at a lower rate and you slowly taper up every 15 minutes. Okay. So that's how you recharge paclitaxel.
Yes, yes,
Okay, so you can give your Avil, your Hydrocort, make sure the vitals are stable again, and then consider rechallenging at a decreased rate and slowly taper up the rate. So that's
yes,
how you generally tend to recharge. Okay,
yes.
so then what are some of the side effects of? Okay, I'd like to say if the patient cannot take, okay, the patient does not comes to a scenario the patient does not want to take oral pre-medication. What is an alternative to that?
Hydrocort IV we give before, so
Yeah,
100
you can give Dexa 20 mg IV instead of 8
Okay.
mg. Okay, so that is another alternative option for patients who do not want to take that 20 mg at 12 hours and 6 hours. You can give 20 mg IV pre-paclitaxel. Okay, that is another thing. Then another thing we need to know here is that right. So following paclitaxel, you give carboplatin AUC 5 or 6 in 5% dextrose over 1 hour, and following that, you give your anti-emetic medication. So only level 4 antiemesis is needed. So you can give, you know, as per the original guidelines, it's only Dexa 4 mg BD into 3 days with Pantop. But in most of our settings, we give Emiset and Dexa. Some people give Dexa along with Pantop, or some people give Emiset and Dexa with Pantop. So depending on what you do in your institute, you can do that. We do not give olanzapine because it's only level 3 antiemesis that we need here. Okay, so I hope you got that. Now, why
Yes.
don't you give carboplatin before paclitaxel?
Uh, so because paclitaxel given before is shown to have better efficacy, and there's one more
See, the main
reason.
reason I'll tell you is because if you give carboplatin before, right, it has to do with plasma protein binding, right?
Yes,
So if you give carboplatin before, it will cause increased myelosuppression. Okay, so this sequence causes less myelosuppression. That's why we always give uh, paclitaxel before carboplatin rather than the platinum before paclitaxel. So due to increased myelosuppression that is seen. So it has to do with the toxicity. Okay.
yes, yes.
Okay. So now coming, okay, that's all good. Now, what about addition of bevacizumab?
So, sir, if it is a stage 3 inoperable disease or inoptimally reduced disease, if there's residual disease of stage 3 or stage 4 disease, then with or there's ascites, pleural effusion. So, these cases we should consider adding bevacizumab from
Yeah.
the neoadjuvant.
Yeah. So in case of neoadjuvant setting, actually, the trials will talk about the evidence of adding bevacizumab later. The adjuvant, when you're giving adjuvant bevacizumab, right? The trials were
Yes,
initially the GOG trial was there, the ICON 7 trial was there. Both these trials
yes,
looked at adjuvant bevacizumab. That was post cytoreduction, giving chemo bevacizumab, right?
yes,
So mainly these trials, the benefit was seen in stage 3 with less than optimal cytoreduction and stage 4 disease. Okay. So when you come to neoadjuvant treatment, the data is less actually. Okay.
yes,
But if the patient is not meeting the criteria for resectability, we can consider giving in all patients. Unless there are contraindications to giving bevacizumab, you can consider giving in all patients. Okay. When you're giving bevacizumab, what is the dose given?
So 7.5 mg per kg we give at
Yeah,
our.
so two doses are there, 15 milligram per kg is there, 7.5 milligram per kg is there. Some people give the lower dose to prevent toxicities. Okay. And do you give it for all 3 cycles of NACT or?
No, we skipped one cycle just before the surgery.
Yeah, very good. Why is that?
To prevent intra-op complications of perforation, bleeding, delayed wound healing, all
Yeah,
this kind
so
of.
exactly, you're right. So when you're giving NACT, C1 to C1 and C2, you give Sumab, and the third cycle you omit it because it can cause complications, like she rightly pointed out. Uh, delayed wound healing, fistula formation, increased bleeding, all that, right? So bevacizumab, as we all know, is an anti-VEGF inhibitor. Um, Side effects include hypertension. It can cause venous and arterial thrombosis. It can cause bleeding. It can cause proteinuria. It can cause delayed wound healing. It can cause fistula formation. It can cause CNS symptoms. So all that needs to be kept in mind, and that's how we give the drug. Okay, in your NACT setting. Now, the next step in this process is your cytoreductive surgery, right? So
Yes.
you have given an NACT. Do we straight away go to CRS, or what is there before that?
We do an imaging before it to
Yeah,
see for the
very,
response.
very good. So you need to do, mention this in the exam as well. Need to do an imaging, CT, thorax, abdomen, and pelvis. Make sure, discuss in the MDT again. So mention, we'll revisit the case in the MDT, make sure that it is resectable, and then proceed for CRS. Okay.
Yes.
So what are the steps of cytoreductive surgery?
We take a midline incision first so that we can uh, see the whole abdomen inside. Then we inspect the whole abdomen. We take multiple biopsies. We cover the paracolic gutters, the subdiaphragmatic space, and the rectouterine and vesicouterine pouches. Then we do omentectomy. So infracolic colic omentectomy uh, we do most of the times, and we do then we go to the ovaries, bilateral salpingo-oophorectomy plus the hysterectomy if as indicated. And
What about the lymph nodes for this particular
lymph
case?
node dissection we do. So advanced cases, as per the Lion trial, only clinically positive or
Yeah,
those
very
well
good. Yeah,
were removed.
yeah. Yeah, so you're right. So like you said, you do a midline incision. It should be an open laparotomy. There is no role for laparoscopy or robotic surgery, right? It's not approved. It's always a midline open laparotomy. You do
Yes.
a peritoneal lavage, right? Or aspiration of ascites if it is present.
Yes.
And you visualize all the peritoneal surfaces and suspicious peritoneal surfaces or adhesions, they are excised or biopsied. In the absence of any suspicious areas, you do random peritoneal biopsies from the pelvis, paracolic gutters, and undersurface of the diaphragm. Then you do a bilateral salpingo-oophorectomy plus hysterectomy with effort to keep the mass encapsulated during removal.
Yes.
Excuse me. And you always do an infracolic omentectomy. If the omentum seems to be involved, you do a complete omentectomy. Then coming to lymph node dissection, you only remove the visible nodes, right? As per, like you rightly pointed out, based on the Lion trial, there's no difference in OS or PFS of doing a complete lymph node dissection in advanced cases. Okay. Now, of course, if this was an early case, we'll have to do a lymph node dissection, right?
Yes.
Yeah. So if it is a stage 1 or stage 2 disease, as per the imaging, there we need to do a lymph node dissection. The reason for that is that around 10 to 30% of up to 30% of the cases can be upstage to advance, right? When we do a lymph node dissection. So in early cases, you do lymph node dissection. In advanced cases, you only remove the clinically positive nodes. Okay.
Yes.
So that's something that you need to remember.
Yes.
So you have done that, and then you've done your surgery, right? So we mentioned the surgery. What is the, can you tell me what is completeness of cytoreduction score?
CRS scores,
Yeah, CC score.
CC score.
CC 0, 1, 2, 3. What they mean?
The CC3 is that it's good.
Yeah.
I don't remember
So
the
I'll
contour.
just tell you. So always remember the CC0 is no visible tumor. CC1 is less than 0.25 centimeters. CC2 is 0.25 centimeters to 2.5 centimeters, and CC3 is greater than 2.5 centimeters. Anything that is CC0 or CC1, right? So anything that is less than 0.25 centimeters or no visible tumor, the CC0 and CC1 is considered to be optimal cytoreduction. Okay. In this
Yes.
day and age, that is the definition. Okay.
Yes. Yes.
Okay, now another important thing when we talk about an advanced case, which is what you usually get in your exam. Not usually, that is what they keep. Okay. So in advanced cases, you need to there's another treatment that you can give post-op. What is that called?
So HIPEC during
Yeah.
surgery.
So what is the rationale for HIPEC?
So it is heated chemotherapy, which is confined to the peritoneum. So the blood peritoneal barrier is there. So it is confined there, and the chemotherapy efficacy is also increased due to the heat and permeability. And
Yeah, so you're right. So you have high concentration at the peritoneal site with low systemic levels, right? Due to the
yeah,
plasma peritoneal barrier.
yes,
And it is uniformly distributed throughout the peritoneal surfaces.
yes,
And one more thing is that we always emphasize complete, that is optimal site reduction, CC score of 0 or 1, because
yes,
these chemotherapy agents can only penetrate up to a distance of 3 to 5 millimeters. Okay.
yes.
So that is the rationale for HIPEC. Now, what they tend to ask you here is, what is the effect of hyperthermia? So I'll just quickly mention that it has a direct action by breaking up DNA strands. It increases permeability and cytotoxicity of the chemotherapy drugs. It increases drug concentration, and what do you call it inhibits repair mechanisms. So those are the mechanisms of action of hyperthermia. So the temperature used is usually 40 to 43 degrees Celsius. Okay. Now, what must the drug properties be to optimally function in HIPEC? So it
So
must
no,
not be, yeah, please go.
so non-cell specific. It should be not
Okay.
specific to a certain. Uh,
Yeah, so that is, you're right. So I'll just quickly enumerate because
yes,
we're running out of time. So not a prodrug. It should be cell cycle non-specific, like you said. It should have clinical activity against the malignancy being treated. It should be a non-vesicant. It should be synergistic with heat, and it should have rapid metabolism to non-toxic metabolite during first pass metabolism in the liver, and should have rapid clearance from systemic circulation. So if all these points are met, it is an ideal drug for HIPEC. Okay. So what is the drug used in case of CE ovary, and what is the dose?
so cisplatin we use, and we use 100 mg of cisplatin.
Yeah, 100 milligram per meter square cisplatin is
Okay.
used. It is given over a perfusion time of 90 minutes, right?
Yes.
Okay. So one more thing I'd like to ask you is, what are the different methods of HIPEC?
So there's pressurized intraperitoneal chemotherapy, PIPAC.
So that's not the answer. It's open and closed. Okay. So one is
Okay.
open, where the abdominal cavity is kept open, right? So that's
Yes.
also called the Coliseum technique. Issue with that is that basically, with the open technique, there's heat dissipation. Okay, so it makes it difficult to attain the perfect temperature, and also the personnel who are doing the treatment, they get exposed to chemotherapy. Okay, but the good thing is that because it is open, the heat and the chemotherapy is adequately distributed throughout the abdominal cavity equally. Okay, so there's no pooling of temperature or chemotherapeutic agent. The next thing is closed. In closed, once again, there's disadvantages. There's uneven distribution, but there's minimal heat loss and minimal contact of staff with chemotherapy. So that's the advantage of open and closed.
Yes.
Now, you just also need to remember some of the contraindications of HIPEC. Okay, I'll just quickly go through that. So the absolute contraindications include, if they ask you, so if you have extra abdominal disease, if you have unresectable liver mets, if you have mesenteric root infiltration, if you have massive involvement of vertebral nodes, if you have suspected, extensive short bowel involvement. So most of those unresectability criteria are there. Then relative contraindications includes bowel obstruction at the time of HIPEC, non-responders to NACT, then high BMI of greater than 40, history of pelvic irradiation, so extensive intraperitoneal adhesions. So all these are, absolute as well as relative contraindications for HIPEC that you need to remember. Okay, some other techniques that have evolved that are related to HIPEC, although they're not used in routine practice and we don't have much evidence for that, is PIPEC, that is pressurized intraperitoneal aerosol chemotherapy, right? And EPIC is also there, early post-op intraperitoneal chemotherapy. So you can just read up on that, just one or two sentences, if you will. those are also other techniques that are used, but there's not a lot of concrete evidence for that. It's not used in routine treatment. So I won't talk further about that. Now, what is the evidence for your HIPEC, right? You have the OV HIPEC trial, which is a phase 3 trial, and it's in stage 3 disease post NACT, where you had interval debulking surgery, and post surgery you give HIPEC or you did surgery alone, followed by adjuvant chemotherapy, right? There also in that trial they use 100 milligram per meter square, given a 90-minute perfusion time. They also use sodium thiosulfate at the start of perfusion to decrease the nephrotoxicity, autotoxicity, etc. of cisplatin. Okay, so there they showed a PFS benefit and a OS benefit, which is significant. Then you currently have the OV HIPEC 2 trial, which is currently going on. This is being done in the upfront surgery setting. Okay, so this is an interval debulking where it's currently approved. They're also looking at whether it can be done in the upfront surgery setting. So those are the two data points for that. Okay, now moving on. You have done your your interval debulking surgery, and you've also done your HIPEC. Okay, now what is there to complete the treatment?
So adjuvant, I didn't.
Yeah, so you're right. Adjuvant chemotherapy, you give 3 more cycles, right?
3 more cycles, yes.
Plus or minus bevacizumab.
Bevacizumab.
Okay, so that's the main treatment. So 3 cycles of NACT plus or minus bevacizumab. You do your interval debulking surgery. You do your adjuvant HIPEC. Then you give your adjuvant chemotherapy. The 4th cycle, that is the first cycle after surgery, you omit bevacizumab once again. Okay, and you start giving it from the 5th and 6th cycle onwards. Okay, now of course the next part of treatment is maintenance. Before we get into that, what are some scenarios where suppose let's go away from this scenario. Suppose the patient is an upfront resectable disease, right? Where are the scenarios where you'll not give adjuvant chemotherapy?
So stage 1,
Yeah.
1A. So stage 1 we give chemotherapy only if it is grade 3 clear cell or C, 1C.
So I'll just quickly mention that. So no adjuvant chemotherapy. Going for upfront surgery, you can omit adjuvant chemotherapy to stage 1A, grade 1 and 2 for serous and endometrioid. Okay. For mucinous, so for serous, endometrioid and clear cell, stage 1A, grade 1 and 2, you can omit adjuvant chemotherapy. Now for mucinous, for stage 1A and 1B also, you can omit adjuvant chemotherapy. Okay. Now, there's another thing that you need to do. When you're doing your upfront CRS, right? So once you do your bilateral salpingectomy and salpingoophorectomy and hysterectomy, you also need to send a frozen section, okay? Because you're not unlike interval debulking surgery where before NACT you do a biopsy. When you go for upfront CRS, that's primary cytoreductive surgery, you do not do a biopsy, right? So once you have resected it out, you need to do, before doing extensive surgical staging, you need to do a frozen section to make sure that it is malignant before proceeding to the rest of the staging surgery. Okay. So that is also very important. Now, now let us look at the conditions where you do fertility preserving surgery. So that includes stage 1A, grade 1 and 2, right? And stage 1C, grade 1. So stage 1A, grade 1 and 2, and stage 1C, grade 1. Okay, stage 1B, you usually tend to, you cannot do fertility preservation, obviously, because bilateral ovaries involved, right? So I hope you got that. So in fertility preserving surgery, you will preserve the uterus. You will only do unilateral bilateral you only do unilateral salpingoophorectomy, and you'll do the rest of the full cytoreductive procedure. You'll do it. Okay. So now moving on. So what is the data? Do we need to give cisplatin? What is the trial that led to replacing cisplatin with carboplatin?
So GOG 0111 trials. It was a GOG.
Yeah. So basically, it was the yeah, you're right. It is the GOG trial, GOG 158 trial, where they compared cisplatin versus carboplatin plus paclitaxel. They found that there was increased toxicity, right, with cisplatin in terms of your neurotoxicity in terms of nephrotoxicity, autotoxicity, etc. What is the main toxicity of carboplatin, by the way?
Myelosuppression.
Yeah, so myelosuppression is the main toxicity. Okay. Now, so cisplatin is carboplatin. So we all use carboplatin nowadays. Okay. Now, suppose the patient is a diabetic patient, is got severe peripheral neuropathy. How should we modify our chemotherapy regimen?
The docetaxel instead of paclitaxel we use carboplatin.
Okay, what is the dose of docetaxel?
So 75 mg per meter square, 3
Okay.
weeks, 21
Yeah.
days.
What is the trial, the data that we have?
The Scott Rock trial.
Yeah, it showed that you can replace paclitaxel with docetaxel, right?
Yes,
There is more myelosuppression with docetaxel, but less neuropathy. Okay,
neuropathy.
before you're giving docetaxel, what is the how do you give the steroid pre-medication, and what do you
Dexa
give it for?
Dexa 8 mg BD 1 day before we give, and it reduces water retention, the
Yeah, so
swelling,
1 day before, then?
and 1 day after, sir.
Yeah,
As
so
per
1 day before, so day 0, day 1, and day 3, you should give Dexa 8 mg BD. And like you rightly said, so docetaxel causes increased capillary permeability. Okay. So it can cause edema, peripheral edema, and severe cases can cause pleural effusion, pericardial effusion as well. So that's in severe cases, but mostly you get patients with peripheral edema. So that's why you give docetaxel. Also, it can cause hypersensitivity reactions due to what preservative?
polysorbate, sir.
Yeah, so polysorbate 80, right? So that's why you give Dexa for both those reasons, actually, to decrease hypersensitivity as well as to prevent fluid retention. Okay, so this polysorbate 80, can you name other agents used in cancer treatment that have polysorbate 80 with preservative as the preservative? I'll just quickly mention it. So you have cabazitaxel, along with docetaxel, you have cabazitaxel. You have
Yes.
fosaprepitant, right? That also has polysorbate 80. You have etoposide, that is polysorbate 80. You have cyclosporin, that is used in transplant setting as an immunosuppressant, that also has polysorbate 80. Okay, so just like an added question there.
Yes.
Okay, so is there any option of decreasing, suppose you have gone for upfront resection, what is the evidence to give 3 cycles versus 6? Is there any evidence for that?
Yes, sir. For mucinous histology or clear cell, they are not very chemo sensitive, so it's contradictory. But you can give 3 cycles
Yeah,
of pack.
so I'll just clear that. You have a GOG 157 trial, which looked at 3 versus 6 cycles of carboplatin plus paclitaxel in stage 1 and stage 2 disease, right? And what they found was that there was no significant difference between recurrence and death rates uh, for 3 versus 6 cycles. On subgroup analysis, for stage 1, there was differences based on histology. So high-grade serous, there was a decrease in control rates with 3 cycles. So there, high-grade serous, you need to give 6 cycles regardless. For stage 1, however, in clear cell, mucinous, and endometrioid, you could get away with 3 cycles. Okay. But for stage 2, all patients, you should give 6 cycles. So that's what the trial shows. Stage 1, high-grade serous, 6 cycles you should give. Stage 1, clear cell, mucinous, or endometrioid, you can get away with 3 cycles, but some people still prefer to give 6. And stage 2, you should give 6 cycles. Okay.
Yes.
Now, what is the role of intraperitoneal chemotherapy?
So in a optimally cytoreduced patient, after NACT, if a patient is given, we can
Yeah. So that's why I asked this question. So HIPEC is different,
mix it.
intraperitoneal chemotherapy is different. Okay.
Yes.
So you can give regular chemotherapy as intraperitoneal form as well. That is also tried. Okay.
Yes.
So usually the dose that was used was you would give right. So you would give paclitaxel. So this was based on the GOG trial. So paclitaxel is given at 135 milligram per meter square IV initially. Then you had cisplatin 100 milligram per meter square IP intraperitoneally on day 2, and paclitaxel 60 milligram per meter square intraperitoneally on day 8. It
Yes.
showed a PFS benefit and an OS benefit in some trials, although other trials did not show this benefit, but it has been discontinued and not in favor because of increased toxicity. Okay.
Yes.
So sometimes if you're answering really well, the examiner will ask you, what is the role of intraperitoneal chemotherapy. This is not, you should not confuse it with HIPEC, and you should also know the doses and the current statin. Okay.
Yes.
Now, dosed and paclitaxel, right?
Yes.
Should dosed and paclitaxel be the standard of care?
No, sir.
Okay, what is the data we have in favor and against?
So in favor, there's only one trial, the JCOG trial.
Yeah,
Which
what is the
was,
dosage of weekly paclitaxel given there?
say, 80 mg per meter square, and 3 weekly carboplatin was
Okay,
given.
yeah. So 80 milligram per meter square, day 1, 8, and 15 was given along with your regular, 3 weekly carboplatin. Okay, that trial showed a PFS and OS benefit.
Was benefit.
Then they had 3 Western trials, that is the MITO 7 trial, the GOG 262 trial, and the ICON 8 trial. And actually, all these 3 trials were largely negative trials. And basically, they concluded that it could be due to a difference in metabolism between Asian as well as Western populations, right?
Yes.
So what is the proposed added benefit of the mechanism of action, the difference in mechanism of action by giving dosed and paclitaxel?
So the metronomic action of paclitaxel, like smaller doses given frequently,
So
and
the answer should be anti-VEGF effect. Okay.
yes.
Paclitaxel, when given on weekly basis, actually has an anti-VEGF effect
Yes.
that can increase its efficacy. So that's the rationale they gave for weekly paclitaxel. Okay.
Yes.
Okay. Now moving on. So maintenance bevacizumab has been tried. Like we mentioned earlier, the phase 3 data is for upfront surgery followed by adjuvant setting, although we currently use it in neoadjuvant setting as well. In the neoadjuvant setting, we have a phase 2 trial, that is the Anthelia trial, which looked at the feasibility of giving it with neoadjuvant chemotherapy. You can read up on that. But the adjuvant setting, you had the GOG 218 and ICON 7 trial, and which showed a PFS benefit with adding bevacizumab, and the majority. So in the GOG 218 trial, bevacizumab was given at 15 milligram per kg, right, from cycle 2 to cycle 6 in the adjuvant setting, and post that maintenance was given from cycle 7 to cycle 22. Okay, so cycle 2 to cycle 6 with chemotherapy in adjuvant setting, and cycle 7 to cycle 22 at a dose of 15 milligram per kg. In ICON 7, it was given at a lower dose, 7.5 milligram per kg, and that was given cycle 2 to cycle 6, and then for 12 cycles post chemotherapy. Okay, so both these trials showed that the benefit, the quantum of benefit with bevacizumab was seen in patients who had stage 3, less than optimal debulking, and stage 4 disease. Okay, we give it in NACT for technically unresectable disease because we want to increase the response rates. Okay, so that is why we give it an NACT. But when you're giving an adjuvant setting, you should always remember, because the trials show that the quantum of benefit is in stage 3 suboptimally reduced and stage 4 disease. Okay, so let us recap what all we have done for this patient, right? You've done your CA 125 CEA, you've done your ultrasound, you've done a CT thorax, abdomen, pelvis, you have done your plus or minus laparoscopy, you have discussed an MDT, you have made sure that the patient is unresectable, you've taken up for an ACT plus or minus bevacizumab, you've done your cytoreductive surgery, you've done your HIPEC, you've given your adjuvant chemotherapy. Next step is
Maintenance therapy. So
yeah.
BRCA directive.
Yeah. So just before I ask you, germline BRCA mutations are seen in around 15% of ovarian cancers. Then you have somatic BRCA mutations, which are seen in around 10%. So around 25% have either germline or somatic BRCA. Rest, around 50% of the cases, including the case of BRCA mutation, around 50% of the cases have homologous recombination deficiency. Okay, so there can be a mutation in other other genes apart from BRCA1 and BRCA2 that are used in homologous recombination repairs. For example, RAD51C, RAD51D, PALB2, ATM, BRIP1. All these can be involved in homologous recombination repair, and when there's a mutation there, it can lead to HRD status, right? So, like I said, 15% germline BRCA mutate, somatic BRCA and 10%, overall BRCA mutate 25%, and HRD status in 50% of the patients. So, what are our maintenance options based on the data that we have? I'll give you a clue. We have 4 maintenance options. Please tell me what those are.
So we have olaparib, then rucaparib, niraparib, and veliparib. So these are the options. So based on the scenarios we choose. So if it is BRCA positive HRD or somatic BRCA, then we give olaparib. Rucaparib and niraparib can also be given irrespective of the HRD status. And so veliparib, so I'm not sure about veliparib.
Yeah. So I'll just tell you the approved things. So you have before that, like I said, you do in our workup for treatment, right? We have done our based on the tumor tissue, we have done BRCA testing as well as HRD status, and we have also done separately from blood or saliva germline BRCA testing. Okay, so we should do that in all cases of CA ovary actually. And following that, so HRD testing is done via the MIRAT testing thing. And a score of greater than 42 or more is considered to be positive. We look at three things, right? So we look at loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions. So LST, telomeric allelic imbalance, and loss of heterozygosity. So these three are surrogates for genomic instability. And if the score is greater than 42 or more, it's considered to be HRD, that is homologous recombination deficient. Okay, so what are we doing with HRD testing, with this myriad testing? We are not testing individually for all the HRR genes, right? We are only testing for BRCA, and for the remaining genes that I mentioned, we are not testing individually. Rather than testing individually, we are looking for the scar or the another indirectly testing for it by looking for genomic instability, by looking at loss of heterozygosity, large-scale state transitions, and telomeric allelic imbalance. So these three factors we are looking at, which indirectly points at a mutation in these HRR genes that I mentioned. And that's how we look for HRD status, and a score of greater than 42 is positive. I hope you all understood that.
Yes.
So the approved drugs are, so we have got, based on the Solo 1 trial, we have got olaparib alone, right? For 2 years, 300 mg BD. Then based on the Paula 1 trial, you have olaparib plus bevacizumab. And in this trial, the patients were started off on bevacizumab with chemotherapy and continued on bevacizumab with olaparib 300 mg BD. Both these trials showed a PFS benefit. The Solo 1 trial, which is the longest follow-up, showed a 21% overall survival absolute benefit. Okay, so Solo 1, olaparib alone, 300 mg BD for 2 years. Paula 1 trial, olaparib 300 mg BD plus bevacizumab for 2 years. Then you have the Prima trial. So the Solo trial was in germline somatic BRCA mutated patients. That's where the benefit was seen. Paula 1 trial, it was done in all HRD mutated patients, right? So HRD mutated. So that is around 50% of ovarian cancer patients. Olaparib plus bevacizumab for 2 years. Then coming to the Prima trial, the Prima trial was basically niraparib 300 mg OD for 3 years. Now they looked at the benefit in germline somatic BRCA, they looked at the benefit in HRD, they looked at the benefit in patients with HRR status, that is normal homologous recombination repair. And in all three patient subgroups, it had benefit. So niraparib is approved for 3 years, 300 mg OD in all patient subgroups. Okay. Unlike olaparib or olaparib plus bevacizumab, where olaparib is approved only in germline somatic BRCA, olaparib plus bevacizumab is approved in HRD only. Niraparib is approved in all settings. Athena Mona looked at rucaparib 600 mg BD, 600 mg BD for 2 years. Okay, and that was once again approved in HRR, HRD, as well as germline somatic or germline BRCA mutated. So all three patient subgroups, one rucaparib 600 mg BD for 2 years was also approved. So I hope you got the doses, I hope you got the duration, the trials, and the setting in which each drug is approved. That is very important. Now, since PARP inhibitors are so commonly used nowadays, okay, like you can't get away from them. So we need to also know, sorry, right. So we also need to know regarding PARP inhibitors, the side effects. That is also very important. Okay. So basically it causes severe nausea, vomiting. Okay. You can consider giving PPIs and, your ondansetron SS. So nausea, vomiting, it can also cause constipation. It can cause myelosuppression in the form of anemia, right? More than neutropenia or thrombocytopenia. So anemia is the most common, form of myelosuppression. It can cause fatigue. It can cause asthenia, right? And one thing that we need to note here is that when there is myelosuppression that is prolonged, right? So once the patient has grade 3 or grade 4 myelosuppression, we stop the PARPA inhibitor and we check weekly CBC. If the myelosuppression is prolonged for greater than 1 month, you might have to consider doing a bone marrow to rule out AML or MDS. Now, AML or MDS in the first line setting in the solo trial was only 1.5% of cases. Okay, so it is very low. So you need not you know, you need to explain to the patient that the incidence of AML MDS is only 1.5%. But if this prolonged myelosuppression, you should monitor weekly with CBC. If the myelosuppression is prolonged without improving for more than 1 month, you should do a bone marrow biopsy. Okay. Now, pneumonitis is also seen, although it is very rare. And niraparib can cause CNS symptoms like headache, dizziness, insomnia, hypertension, because it can penetrate the blood-brain barrier. Okay. Another thing to notice is for rucaparib and olaparib, it can also cause an increase in serum creatinine because it's excreted mainly through the kidneys. And yeah, rucaparib and olaparib. And rucaparib can also cause hepatitis. Okay, so it can cause transaminitis. So these are the side effects. If you answer all these, I think you'll be in good. I think you've answered most of them. Okay. Now, we have covered maintenance now. I hope you all got that. So maintenance options are bevacizumab and PARP inhibitors, which are currently used. Now, how will you follow up this patient?
So every 3 months, we will do a clinical examination history and CA-125. USG, if USG is abnormal, then we'll go for further imaging. So for the first year, every 3 months. Next year, you can go to 3 to 6 months, and then later after that, every 6 months for the next 2 years, and then yearly.
Yeah, so a very important thing to note here is that there's no role of imaging, okay, on a regular basis. You only do physical examination, okay?
Yes.
So you'll do your history and physical examination, including a per abdomen and a PVPR. So that's what you'll generally tend to do. And you will do that initially 3 monthly for 2 years, along with CA-125, okay? So if you have a rise in CA-125, or if you have the patient has symptoms, only then you will do imaging. Okay. So
Yes.
you'll monitor with history and physical examination CA-125, 3 monthly for the first 2 years, then 6 monthly for the next 3 years. If there's a rise in CA-125 or if the patient is symptomatic, then you will do a imaging. Okay. Now, in the imaging, you will look at whether the patient is resectable or not. Okay. So for resectability on progression, there's something known as the AGO criteria. Okay. So the AGO score is based on the desktop trial, and the AGO score consists of these features. So whether the patient had complete resection at initial surgery, whether the patient has an ECOG 0 status, and it also looks at the absence of ascites that is less than 500 ml. Okay. So complete resection at initial surgery, ECOG status of 0, absence of ascites that is less than 500 ml. If all these criteria is met, plus the patient is currently resectable, right? And if the patient doesn't have, so complete resection at initial surgery, ECOG 0, absence of ascites, and if the patient is currently resectable, so if all these criteria are met, that is the AGO criteria, then you would consider for, secondary cytoreduction. Okay. So on follow-up, you will do history and physical examination plus CA-125. If there's symptoms or if CA-125 rises, you will do an ultrasound or CT, thorax, abdomen, and pelvis. You'll look at whether the patient fits into the AGO criteria. If they fit into the AGO criteria, you'll go for resection followed by second-line chemotherapy. If the patient does not fit into the AGO criteria, and if the patient is only mildly symptomatic, right? Regardless of the rise in CA-125, if the patient does not fit into the AGO criteria, or if the patient is not symptomatic or just mildly symptomatic, you should continue follow-up. Okay. So that is the message that you should know. When there is increase in CA-125, or if the patient has symptoms, you should do an ultrasound or CT scan and look at the resectability based on the AGO criteria. If the patient does not come into the AGO criteria, and if the patient just has a rise in CA-125 without any symptomatology, then you can keep the patient on follow-up till the patient becomes symptomatic, because we are not planning for resection in such a patient, right? So there's no point in jumping and treating just with a rise in CA125 in an unresectable case. In an unresectable case, regardless of the CA125, only treat if symptomatic. So this is the most important question that they'll ask you with regards to CA ovary in your exams. Trust me. If you get this right, they'll be very happy, the examiners. So know how to monitor, when to intervene with resectability based on AGO criteria. If unresectable, only if the patient is symptomatic, you need to intervene. If the patient is asymptomatic, continue follow-up. There's no benefit of starting off on second-line therapy if the patient is unresectable. Only start off on second-line therapy if the patient is symptomatic. For this, we have a EORTC trial, which has shown no benefit of starting off early with chemotherapy. In a patient who is unresectable, right? There's no benefit of starting off with chemotherapy. Now, moving on. So now we need to talk about, something, relapse, right? When we talk about relapse in CE ovary, earlier it was classified into platinum refractory, that is, it progresses during treatment or less than 1 month after treatment, platinum resistant, that is 1 to 6 months, partially platinum sensitive, that is 6 to 12 months, and greater than 12 months, which is fully platinum sensitive, right? This classification is based on the GCIG 2010 classification. That is now obsolete. Okay. So currently, based on the 2016 GCIG classification, it is now termed as treatment-free interval P, which is treatment-free interval platinum, treatment-free interval non-platinum, treatment-free interval B, which stands for biological agent. So TFIP, TFINP, that is non-platinum, and TFIB, which is biological agent. So you have to describe the recurrence based on these three definitions. Okay, TFIP, TFINP, and TFIB. So based on this, the ESMO criteria 2018, they have divided patients into platinum eligible and platinum non-eligible. So earlier the concept was for platinum resistant, that is 1 to 6 months. You can't re-challenge with platinum-based therapy. That concept has now gone, because now we have seen that for certain cases of platinum resistant, that is those who relapse between 1 to 6 months, platinum re-challenge can still benefit. That has been seen in various trials. So that concept of platinum refractory resistant, partially platinum sensitive or fully platinum sensitive is now gone. You base it based on TFI, P, NP, and B. And it is classified into platinum eligible and non-eligible. So platinum non-eligible is progression on treatment. So you're giving first-line treatment, there was progression on treatment, or if the patient had refractory disease, so less than 1 month after treatment it progressed, that those patients, there might not be a benefit of re-challenging up with platinum again, or patients with contraindication for platinum therapy, right? Like neurotoxicity, nephrotoxicity, etc. Then you have the second group is platinum eligible. So that is how we have divided our treatment. And so now for the platinum, So for the platinum, for the platinum ineligible group, right, you'll give a single agent treatment. So yeah, someone has rightly mentioned in the chat, you can give lipodox, you can give topotecan, you can give single agent gemcitabine, right? All those are options. You can give, there's another option, trabectedin plus liposomal doxorubicin, right? So all those are various options. Single agent lipodox, topotecan, what do you call it? Trabectedin plus liposomal doxorubicin, etc. Or single agent gemcitabine, or single agent weekly paclitaxel. So all these are options in your platinum ineligible group. Okay. I hope you understood the definition of platinum eligible. That is refractory disease, progresses during treatment or less than 1 month after treatment, or is not eligible to receive platinum-based therapy due to nephrotoxicity, neurotoxicity, cardiac failure, etc. So that is how you treat platinum ineligible. Okay. Now with the single agent treatment, you can also add bevacizumab. We have data for that based on the Aurelia trial, which showed that with your single agent weekly paclitaxel, topotecan, liposomal doxorubicin, you can add bevacizumab that has the PFS benefit. Okay. Now, for your platinum eligible, if the so we're getting there. Wait. For platinum eligible, you can re-challenge with a platinum based therapy. the treatment of choice in platinum eligible, right? So you can rechallenge with carbopacly, but we have data. So we have data in the form of the Calypso trial, which looked at carbopacly versus carbopacly plus liposomal doxorubicin, and it showed that there was a PFS benefit for giving carboplatin plus liposomal doxorubicin, right? So that is preferred over carbopacly rechallenge itself. So always when you're rechallenging, you should consider with liposomal doxorubicin and carboplatin rather than carboplatin plus paclitaxel in your platinum, um, right, in your platinum eligible subgroup. Okay. And so carboplatin plus liposomal doxorubicin is preferred based on the PFS benefit seen in the Calypso trial. So that is something to remember. And once again, based on the Oceans trial in this setting, you can give bevacizumab with in a platinum sensitive setting. So Oceans trial show that with your carbo platinum and liposomal doxorubicin, you can also give bevacizumab. Okay. Now, further progression, you give regimens that you have not given. So if you rechallenge with carboplatin, liposomal doxorubicin, you can consider giving gemcitabine, weekly paclitaxel, topotecan, etc. Okay, so that's how you give subsequent lines of therapy. If the patient has been given neoadjuvant second line chemotherapy, you do not go for a secondary cytoreduction. There might not be much benefit. Secondary cytoreduction is always done upfront if it is resectable. Post second line treatment, although a lot of private centers do it, there's not a lot of benefit that is seen. Okay, that is something I need to keep in mind, practically speaking. Although private hospital surgeons tend to do it, but that is not preferred based on the data. Okay, so I hope you got that point as well. Now, before we wind up, let me just try to, tell you a few more things. Liposomal doxorubicin, right? What is the infusion time?
So half an hour for
Yeah, so I'll just quickly mention that liposomal doxorubicin is given, if it is given alone, it is given as 50 milligram per meter square. If it is given with carboplatin, it's at 30 milligram per meter square. The first infusion, because it can cause hypersensitivity, should be given over 120 minutes. The second infusion onwards, you can give at 60 minutes. It should be given in 5% dextrose. Okay. Apart from your myelosuppression, your cardiotoxicity, etc., it can also cause oral mucositis, and it can also cause hand-foot syndrome. So you need to counsel the patient regarding these two things as well. Okay. I hope you got that. Now, coming to the use of PARP inhibitors in second line maintenance. So if you have not used in the first line, you can consider using the second line. So olaparib is approved regardless of the, so it is approved regardless of the germline BRCA status or HRD status. There's a Solo 2 trial and a study 19, which is a phase 2 trial. Solo 2 is phase 3, study 19 is phase 2. So based on this, you can give it in all patients who have shown a response to platinum-based therapy, okay, who have not progressed on platinum-based therapy. This is in the second line maintenance setting. And based on the NOVA trial, you can give niraparib, and niraparib is only approved in germline BRCA setting, in the second line maintenance setting. In patients who have shown platinum sensitivity, only in germline BRCA. Olaparib in all settings, niraparib in second line maintenance in germline BRCA only, based on the NOVA trial. And based on the Ariel 3 trial, you can give rucaparib in germline and somatic BRCA setting only in patients who have shown response to platinum therapy. Okay, so those are the 3 approved agents in second line maintenance setting, and those are the indications where you can give it. So that's that. In third line setting, all the PARP inhibitors have been discontinued. Now, just to finish this off quickly, coming to the other agents that can be used, you have mirvetuximab soravtansine, right? It's a folate receptor alpha antagonist, and it can be given. It's shown, PFS and OS benefit in advanced setting post multiple lines. If the patient has MSI high status or DMMR status, you can give dostarlimab, you can give pembrolizumab, right? And if IHC 3 plus, you can give TDXT. So those are the tumor agnostic indications. Post multiple lines, dostarlimab in DMMR status, pembrolizumab in DMMR or tumor mutation burden greater than 10 mutations per megabase pair. So dostarlimab in DMMR, pembrolizumab in DMMR, or tumor mutational burden greater than 10 mutations per mega base pair. That's based on the Keynote 158 trial. Then TDXT based on the pan tumor trial, IHC 3 plus, all patients you can give TDXT post multiple lines. Okay. And like I mentioned, folate receptor alpha expressing tumors, you can give mirvetuximab soravtansine. So I think that covers it. I think those are generally most of the questions that are asked in this setting. One more thing to remember is keep it simple. I hope you focus more on the foundational aspects, the basics, right? Because that's what the examiners will focus on. And if you can, clear out all those things, you'll be, in good condition for the exam. Thank you, Dr. Aishwarya. You did really well. And we'll see all you guys for the next class.
Thank you.
Thank you very much. Good night. Sorry for keeping everyone very late.
Thank you, sir.